Welcome to the Alive Maryland training. This is Telehealth in Practice from Access to Equity. And we're glad that you could all join us today. My name is TJ Moore. I'm a capacity building manager with Health HIV. And before we get started today, this webinar is available for CME, CE, continuing education credits. I sent out an email this morning to everyone who had registered with instructions on how to claim those credits following this training. If you did not receive that email for some reason, you can shoot me an email at tj@healthhiv.org directly, and I'll be sure and send it to you. I'll put my email in the chat in just a second so you can have access to that. After today's webinar, I will also send an additional email with those same instructions on how to claim those credits. And there will also be a link in there for a survey following this. I'd appreciate it if you would all take just a short amount of time and fill that out. It really helps us moving forward with evaluating how these things go, what we could do better, things of that nature. So I would greatly appreciate if you fill out that survey. And again, if you don't see an email from me with instructions on how to access credits, or if you have any questions regarding that, please feel free to email me directly. Again, I'll put that in the chat in just a minute. So that's enough rambling from me. I'll go ahead and introduce our speaker for today. This is Dr. Kathy Wiberly. Dr. Wiberly is director of the Mid-Atlantic Telehealth Resource Center, and telehealth resource centers are federally funded to assist with telehealth program development and sustainability in order to increase access to quality care for rural and other underserved populations. Dr. Wiberly is also director of research for the Karen S. Rubin Center for Telehealth, assistant professor of public health sciences at the University of Virginia School of Medicine, faculty member at the Healthy Appalachia Institute, and adjunct faculty member in the L. Douglas Wilder School of Government and Public Affairs at Virginia Commonwealth University. Dr. Wiberly's public service career reflects over 30 years of experience in public health, public policy, program development, program evaluation, and strategic planning. She is an appointed member and chair of the Rural Health Committee for the Universal Service Administrative Company Board and is vice president of the Virginia Telehealth Network Board. So we are very lucky to have her join us today. And without further ado, I will turn this over to Dr. Wiberly.
Great, thank you, and good morning. I'm going to go ahead and share my slides real quick. All right, assuming that you can all see that.
Good on our end.
Super. So, as you know, telehealth has really taken off during the pandemic. And one of the things that I like to start with is this. So the tortoise and the hare is kind of a perfect illustration of where telehealth was prior to the pandemic. For most people, most people don't realize that telehealth has actually been around for over 30 years. This year actually marks, or this coming year marks, the 30th anniversary of the first telehealth encounter. And it has slowly grown over time. And the first decade was obviously really, really slow in telehealth growth because of the bandwidth issues and the complexity. And it literally took people time to sit there and hardwire systems together. And the internet was dial-up back then, and it was horrible. But we definitely saw some real growth in the last 20 years as internet speeds improved and software improved. But it was still kind of a slow and steady growth. We didn't see this monumental spike. Then came COVID. And as you all know, COVID was the leader of digital transformation for most of us, most companies, most organizations, from public health to private practice. And we often think about it as, this overnight kind of sensation, but it really has been built on the backbone of 30 years of experience, some of which have developed some great lessons learned. So we have been on this sprint for over almost 2 years now, believe it or not. And I'm just going to quickly say, this is what it was like for us as the Mid-Atlantic Telehealth Resource Center. If you see that huge spike right there with the COVID virus, that was like the first about 6 weeks of the pandemic, and we had a literal 800% increase in technical assistance requests. With questions, with, how do I do this? With what platform do I use? With all the stuff about policies. And the biggest piece was the policy changes. And as you probably all know, those policy changes were weekly, sometimes daily, sometimes twice a day. Things would change, and it was almost impossible to keep up. The impact of COVID on telehealth, I think just it from a payer's claim perspective is really telling. If you just look at just Medicaid and CHIP in general, 2,632% increase in services between that March and June period, from one year to the next for 2020. Crazy. For Medicare, it was very similar. I mean, can you imagine more than 1 in 4 Medicare beneficiaries had a telehealth visit between summer and fall of 2020? You know, Medicare is usually the population where we think, oh, the elderly population, they don't use, you know, they can't use telehealth, they don't understand technology. Well, 1 in 4 is pretty substantive in that very brief period. It's even more than that now. If we look at all medical claims, so looking at Delaware, Maryland, and Washington region, you also see this huge spike in utilization of claims. Now, granted, some of those claims, because telehealth was kind of, we allowed audio only to be called telehealth during this time. Some of these were definitely audio only and not video, but it's still a huge spike in utilization. So the question I like to ask and oftentimes pose is, why did it actually take a pandemic to get to this point? You know, what was it about the pandemic that changed the whole landscape that quickly, where what normally would have taken 3, 4, 5 years of strategic planning suddenly happened in 2 to 3 months? So I think one of the main reasons is the slow diffusion of innovation. And most of us have read all of the NIH studies and Institute of Medicine reports about this 17-year gap between scientific evidence and patient care. And most of us have looked at this whole innovation curve and how long it takes people to really adopt practices. But we also know that many times there's this lag in our health professions training programs. So when something hits the literature, peer-reviewed journal, whatever, as like a best practice or an effective practice, it takes a really long time before that translates into curriculum material in our health professions education programs. And then it takes that much longer for these people to actually graduate from these programs and go into practice. And so, we rely on kind of CEs or CMEs to disseminate innovation. Well, that's really not the best place to disseminate innovation, because if you want someone to do something completely different, it's really hard to do that in a 1-hour webinar, or just a 2-hour session to change the whole way that you do practice, because that is part of, really hands-on. Like, I want to see it. I want to be able to ask questions. I want to do it. I want someone to be able to walk me through it. And then I need like troubleshooting support and all of that. And so it took a pandemic to force people to do something that they were uncomfortable with, because, status quo is a really big motivator for most people, because it makes things easier. It makes life easier. We know what to expect. Everyone knows what to expect. And so that's part of the slow diffusion of innovation. It also took a pandemic because the culture of innovation is not supported by our policy environment. And I think you in Maryland definitely know this. I know in Virginia, we know this. Whenever you want to make a change, whether it's a policy change, a reimbursement policy change, any kind of change, the question we always get back is, does it work? What does the scientific literature say? So then you like hand over this whole volume of scientific literature. And then the next question is, yes, but is that the case in my state? Maryland is different or Virginia is different. Tell me what it is like. And so you get into this chicken and egg dilemma, right? Because you say, well, if you change the policy, we can give you the data. And then they say, well, if you give us the data, we'll change the policy. And you're kind of just stuck in this never ending cycle. And we very rarely incentivize innovation in our policies. Every now and then you'll see a grant that says, hey, try innovation and tell us what happens and evaluate it. But rarely does that happen. Like, state funds don't usually come down and go, hey, we have this, boatload of money and we want to invest it in innovation. We want you to do something completely different, untried before, and we want to, give you the money to do it and help you evaluate it. So CMMI has done that a little bit, the Centers for Medicare and Medicaid Innovation, and have put a little bit of a carrot in there, try innovation. We're going to give you some grant dollars to do it. But most grants are, show us the evidence base, tell us how well it has worked in the past, and then you can replicate it. Um, so I think we need to think differently about how we use our funds and our dollars. But what did it take on the policy level side? We removed just about all of the policy barriers that there were around telehealth. So reimbursement barriers, kind of uses of technology barriers, state licensure barriers, all of these things, Ryan Haight Act and prescribing of controlled substances. I mean, that policy has been awaiting implementation of regulations for how many years now? And suddenly with the pandemic, oh, we now have a different way of doing this, right? Star clause has been an issue and that needs to be revised. It hasn't been, but at least federally, we kind of relaxed that during the pandemic. So for those of you who aren't familiar with Stark laws, it's the prohibition of kind of creating inducements for referrals. And so how does this impact telehealth? Well, let's say I'm a large medical center or a large facility, or I have pretty, good funds, and I'm working with a small clinic or a free clinic that doesn't have funds and they don't have equipment. And so I go, I'll buy you equipment and give it to you so that you can have telehealth visits. That's perceived as inducing referrals. If you're giving away something, um, the underlying quote unquote motive is, well, then you're doing telehealth visits. So you're trying to bring referrals to your entity so that you can make more money. And so there's been a prohibition against it. There are like little things to get around that, like you can do a lease contract or and kind of a very small amount lease contract for the equipment that you're then renting to them or like leasing to them instead of giving it away. But all of those things were seen as barriers, and they were indeed barriers to really deploying and adopting telehealth broadly and scaling it. So I'm going to hit on a couple of the key policy changes that we saw that made a huge difference. Reimbursement was definitely one of those, and people have always yelled about reimbursement, that we don't have enough adequate in reimbursement, which is the barrier to telehealth. So Medicare, Medicaid, and commercial plans all gave broad flexibility to use telehealth, including telephonic and video via smartphones and other devices. That was big. They reimbursed providers for telehealth in the same manner and or at the same rate as face-to-face services. That was big. And then they started to allow face-to-face service requirements to be met using telehealth. All three of those things combined basically opened up the environment, and people said, hey, I can do these things. I can get reimbursed the way that I would in in-person care, and I can use very simple technology that people already have in their homes. So that was definitely one of the driving forces. Another reimbursement policy change that we saw across all payers was originating site expansions or clarifications. So many payers had limitations, particularly Medicare, on where the originating site, which is where the patient is located, could be. So you had to be in rural, or you had to be in a particular facility, or you had to be in an underserved area, or you had to be in an FQHC or an RHC or some kind of healthcare facility, and the workplace doesn't count, the home doesn't count. Well, all of a sudden, all of the payers said, hey, you know what? Homes can be an eligible originating site. Oh, and yeah, wherever you happen to be, it's fine. And that opened the door for the reimbursement challenges to be eliminated. Another huge expansion was the provider type. So most of our payer sources had limitations on which providers were eligible to get reimbursed for telehealth services. And for the most part, it was physicians, it was nurse practitioners, it was mental health providers, and a certain limitation of them. So, for most states, it was psychologists, LCSWs, licensed professional counselors, and that was about it. Suddenly those restrictions got lifted, and you can now get reimbursed for PT or OT or speech language services, or even some WIC services and public health services. And suddenly people thought, oh, well, we can expand the types of things, we can expand the types of providers. They're all eligible now. FQHCs became eligible to provide telehealth services, which they were actually by law not allowed to under Medicare. And so this was another game changer. Service type expansions, I already mentioned a little bit about that, but we saw in many states, basically they said, if it makes sense to do it by telehealth, just do it. Like any service. Other states just like started growing their list of eligible services. Some of the most common ones that we saw expanded were applied behavioral analysis for kids with autism, rehab services, dental services, wellness visits, home health services, early intervention services. The list just goes on and on. We also saw modality expansions. So what's a modality? Well, it's how we do telehealth, right? Most people think about live video, but there's way more to that. So we saw expansions in remote monitoring. We saw expansions, obviously, in telephone care. We saw expansions in store and forward or asynchronous care. And for those not familiar with that, it's not the real-time stuff, but what you would get if you were doing, let's say, a teledermatology appointment, taking a picture of a wound or a rash, sending it, and then the dermatologist reviews that image, not in real time with the patient, but whenever they happen to have a spare moment, and then sends back some kind of, renders an opinion. But we also saw expansion of patient portal reimbursement. So if you have communications in the patient portal with your patients, whether that's email or secure text messaging or sending images by the patient portal, you're now able to get reimbursed for that. So all of those, I think, lend themselves to greater utilization and certainly greater willingness to for both patients and providers to get involved in telehealth. So given that landscape changed and the policy change, what did everyone actually learn during this pandemic? I think the biggest lesson learned that everyone had was that telehealth technology is simply a tool in the clinician's toolbox. It's not a separate service. Oftentimes people viewed it as, oh yeah, I don't do that telehealth thing. I just provide in-person care. Very rarely do you say, like, you'll hear someone say, I don't do that stethoscope thing. I just do in-person care, right? Like, but stethoscope is simply a tool, just like, an EKG is simply a tool. And so I think people started learning, this is a tool. It's not right for everything. Like, you don't use a stethoscope for everything. You don't need it if someone breaks their ankle. But, there are many use cases where it's very important. It lends valuable information and it builds on what you have. And so I think during these last 6 to 8 months, after the rapid pivot where people are starting to think, okay, so now that I have this tool, what can I do with it? What can't I do with it? And those are the questions that are popping up. So what I am going to focus on for the rest of this presentation is this piece, like what's next? Hopefully we are going to end this pandemic. I assume that we're just going to move into an endemic state and we're just going to be dealing with COVID for a very long time, but at least it won't be killing people, left and right. And our hospitals won't be completely full and, unusable. So now that the genie's out of the box, I don't think we'll ever be able to go back to our pre-existing policies. We've already seen permanent policy changes at the Medicare level, at the state Medicaid level. Still waiting on commercial plans to make some decisions on what's going on with their policies. But I think most of the time, Medicare and Medicaid will drive commercial payers as well to do some of the same things. So let me take a step back with you and just really think about telehealth as a tool now. So most of us are of the age where we have either parents or grandparents, and certainly great-grandparents who grew up in this generation where this picture is how healthcare was delivered. Healthcare was given to the home by the country doctor, who basically came by horse and buggy, and once the car was invented, occasionally the car. But if you really think about it, it was not that long ago. It really has been in, one generation of our lifetimes, most of us, where this was the normal mode of care. Think about where things are now. When I read the stories of, and there's actually a country doctor museum, I think in Arkansas, and I was doing some research for another presentation I was doing and was reading some of these like case notes about, what doctors were doing. And so I'm going to give you a little bit of time. I'll tell this story while you kind of look at this table, because I think we really need to think deeply about how our healthcare is now versus what it was like before. So when I was reading some of these journal entries, you had country doctors saying, so and so had appendicitis, and I went to the home. I called the surgeon came to the home. They performed the operation. I stayed in the home for 3 days overnight to make sure that the patient was successfully recovered before I left. And you think, what? Like, you stayed in the patient's home for 3 days? The surgery was done in the home. You had these clinicians like talking about, oh, I've been treating this family for 3 generations now. I know their grandparents. I coached their baseball, the son's baseball team. Like, all of that just blows my mind because I didn't grow up in that. But when you compare care then to what care is now, I think this is where, the cartoon is a little tongue in cheek. Wow, your cholesterol has me really worried. GAC, you might want to actually look at the patient. Where have we come, and do we actually like where we were pre-pandemic? So the location of care in the past was in the home. We slowly, or actually fairly quickly, moved to all in like facility care. During the 30s, 40s, 50s, we started making that transition. And so now almost all of our care is facility-based care. You require a patient to go somewhere for their care, whether it's a clinic, a physician's office, wherever it is, a hospital, emergency room. The provider was a generalist. Like, your primary care provider really knew a little bit about everything. And they actually knew quite a bit about a lot of things. And now most primary care providers are trained to just handle a subset of things. And then when things get a little bit outside the comfort zone, they refer to a specialist. And so we have this long backlog of like specialists with waiting lists. The interaction used to be very frequent. One of the journal entries said, so-and-so had a common cold. I made 3 visits to their home. Like, common cold, 3 visits to the home. What? This is crazy. Whereas now we have episodic or periodic visits. We treat people who are healthy and we go come back in a year. If they have a chronic disease, they might be recalled in 2 months, 3 months, 6 months. And all we get is a snapshot of what their health is like at the time that they're in the office. So, for example, my mother has low blood pressure and has had low blood pressure all her life. It's always low. And so if she were ever to get to, let's say, a hypertensive state, it would probably take like 3 or 4 decades of slow inching up of her blood pressure. And no one would ever catch that in a, every 6-month, 12-month recall visit, because her blood pressure would be normal at every visit, or at least in the normal range. When we're like measuring a blood pressure like every day and keeping track of that for weeks and months and end, we see that slow uptick very quickly. We see the trend lines. And that is something that telehealth gives us, but that is something where in the past, like when you had those, I visited the home like every day for the common cold for 3 days. And I'm going into the home with the family and seeing what's going on. That changes the landscape of, the number of data points and how well you know that patient. The relationship was very personal. And interestingly enough, we never talked about social determinants of health back in the 10s, 20s, 30s, because everyone knew what the social determinants of health are. The provider lived in the community pretty much in the same neighborhood as the patient. They were in the home, they saw what was going on. But when we moved to facility-based care, we suddenly have to think about what are those social determinants, because the patient may be coming from 10 miles, 20 miles, sometimes 100 miles from where the provider is. You have no idea their context. You don't know the living situation. And so think about, how telehealth is a tool in that perspective, because we will talk about that. The unit of care was always the family back in the day. Now it's very much the individual. You don't, some cultures will bring the whole family in for the visit, but usually it's the individual coming in. And the focus was basically on health. Like, how do we restore people to health and keep them that way? Whereas right now, our visits are much focused on disease. We like to say we focus on prevention, but our focus on prevention is still pretty minimal, unfortunately. You come in if you're sick. You come in sometimes when you're well, but at a pretty, long gap when we see you if you're well. So if the answer to, I'm really not all that pleased with the way that we've been delivering healthcare pre-pandemic, then you really need to think about, and this is where I would encourage you to think about, where can telehealth be used as a tool to facilitate some of those things that we didn't like, and how to fix that. And so when people say, well, what should I do with telehealth? What should we do with, now that we have the infrastructure in place, now that our providers actually know how to do this, or at least somewhat know how to do this, where do we go from here? And the question I like to pose to everyone is, what problem would you like to solve? So for some of you, it's, we have poor care coordination. We have people with multiple conditions, and there's no handoffs between when they exit the hospital to when they come back into the primary care setting, or we have multiple specialists involved in this person's care and none of them are communicating, or we have, patient navigators and people who are, on the social work end really helping to solve some of the social determinants of issue, but they're not having no conversations with the doctor, and the med reconciliation is not happening. And we have, this patient has like 12 different bottles of medications that were prescribed by different providers, and we don't know what the interactions are, and we don't even know why they have all these 12 different bottles. Those are issues that can be solved, and telehealth can be a tool. So thinking about, let's bring all these providers in really quickly for like a 5-minute visit and have a conversation with what's going on. Missed or canceled appointments. We definitely saw and heard a lot of anecdotal evidence during the pandemic from providers, basically saying when we flipped to telehealth, our no-shows like dropped by almost half or more, because people were showing up. Surprise, surprise. Think about all the barriers for people getting to care in person. I couldn't find a sitter. My sitter called at the last minute, had to cancel. I had to take off from work, and my employer suddenly said, I can't take off that day. We have an urgent need, or I'm going to miss hours and I can't pay my rent this month. And I am, paid at a wage salary, and I can't miss 2 hours or 3 hours of work. All of those things come into play. Then you think about people with disabilities and how complicated it is to transport someone who has mobility issues, who might have vision issues. And that all lends to missed and canceled appointments. And we have had complete practices as well as healthcare systems now create a policy that says if a patient ever calls to cancel an appointment, you immediately offer them a telehealth visit. And they have basically flipped the number of canceled appointments into reimbursable telehealth calls. So really thinking about that model. Obviously, access to care was one of the reasons why telehealth came into play. And so, is access to care one of the issues? My patients are traveling a long ways, or even for those of you in inner cities, bus routes have been oftentimes, I know around me, have been cut down because of COVID. So even though they're free, there's less of them. And it's really hard to get from one place to another. And sometimes it's 3 or 4 bus transfers just to get like 5 or 6 miles. And so that's a whole day sometimes out of someone's time to get to a place, then to get back to their workplace or their home. And so access is definitely an issue. Hospital readmissions, is that issue? Are we getting, penalized? Healthcare is one of those weird places where we basically strive to lose less money sometimes. And that's one of the areas where we strive to lose less money. But we think about COVID right now and clinician burnout and turnover and work-life balance. Is that a problem that you're trying to solve? Because I'm hearing this a lot. Clinicians are burnt out. They are doing a lot of care. They have been dealing with the pandemic for almost 2 years now. It's been constant. There's no breaks. On top of that, they're dealing also with the emotional toil of, watching patients die, dealing with the political toil of, everything from vaccinations to, just people still not believing that COVID is real and having to deal with that. So what can we do to help restore some work-life balance for clinicians? Sometimes it's, hey, why don't you work from home and do some telehealth visits on, your Friday? Or, why don't you flex your hours so you can work a few hours and spend some time with your family or your kids, or go to that baseball game and then do some telehealth visits in the evening when you're home. I think those are all ways that we can help to facilitate some of that clinician burnout and that high turnover that we often have. Um, I mentioned the social determinants of health. When you are doing a telehealth visit to someone's home, you get a wealth of information that you wouldn't get in an in-person visit. When you can take a look literally into their refrigerator and you notice that there's no food in there and there's maybe 3 6-packs of beer and that's the only thing that's in the fridge, or you can take a look at the medicine cabinet and realize that they have like 6 prescriptions, all of which they filled like a year ago and none of which they've taken. It gives you a wealth of information that you wouldn't get in the office. When you see the roaches running in the kitchen and the child has asthma and can't control the asthma, it gives you a wealth of information, right? So, as we think about social determinants, what can you use telehealth for? You can really get a glimpse of how this person's living. If this person is having trouble sleeping and you realize that they're in a 2-bedroom apartment with 10 people, that gives you a wealth of information as well. We also think about lack of patient engagement. We often blame the patient for a lot of things. Sometimes it is, sometimes it's rightfully we blame the patient, but oftentimes patient engagement is really, being able to draw that patient into their own care because we're giving information in a timely way when they need it. So when I say, like, when we do periodic or episodic care and the patient comes in the office, they may be feeling great that day. And so they say, like, I'm feeling fine. And so you lose that opportunity that, like, 3 or 4 days ago or 3 weeks ago when they were not feeling fine. Maybe they are hypertensive and they went out and had, the bacon and the salt pork for breakfast and they forgot to take their meds and they were dizzy and feeling awful all day. You never knew that. They never called you about that. They just kind of laid down, took a nap. Next day, they were feeling a little bit better. They got back on their meds. And you missed that educational opportunity to link, why you're feeling bad with behaviors. And so one of the things that remote monitoring does and why it works so well is that it automatically gives you the notification when that blood pressure spikes, and you can call them within 12 hours or 24 hours and say, Mrs. Jones, we noticed like this spike in blood pressure. What happened that day? Well, yeah. And you can walk through, well, we went to the buffet and we did eat, this huge heavy sodium diet. And okay, so let's talk this through. You ate high sodium, you also forgot to take your meds, you started retaining fluid, your weight went up, your blood pressure went up. That's really why you're feeling so bad. So let's think about this. That is a patient engagement piece because they're, suddenly you're talking to them at a point where they're receptive to that information because I'm not feeling good now and I get the connection. So really think about, what is the problem you're trying to solve? And most places have 2 or 3 problems they're trying to solve, some of which are more priority than others. And that problem that you're trying to solve then defines why you're using telehealth. I never say just use telehealth for the sake of using telehealth. There's no real reason for that. But once you define the problem that you're trying to solve, one of the best practices is to identify a clinical champion. What does that mean? The clinical champion is usually a clinician. It doesn't have to be a clinician, but oftentimes it is. It's the clinician who really understands the problem you're trying to solve and is passionate about solving that problem. What is the importance of that? The clinical champion, because they're passionate about solving that problem, is willing to work through the bumps in the road. And I will tell you, like, when you start deploying telehealth, there will be bumps in the road. It's not always like flip the switch, everything works perfectly. Because we all try to figure out workflows. We try to make things better for our patients. We're always going to deal with patients with bandwidth issues and all those things. And the clinician who's a clinical champion is going to say, all right, I hit a bump in the road, but I know that the problem I'm trying to solve is really important. So what can I do to navigate this? What can I do? What's the next iteration? What can we do to try something different to make this work? And they're really dedicated to making something work. And that is the person that you need in your practice, in your office, in whatever work setting you're in, that's willing to stick to it and make it work. Learn the possibilities. I mentioned earlier, there's synchronous, there's asynchronous, but there are also many manifestations of synchronous and asynchronous. Some things are going to work better in different practice settings, in different specialties, in different things that you're trying to solve. But we also need to think about, there's clinician to patient at a healthcare facility, and you can do telehealth between facilities. Um, so sometimes some healthcare systems have built in kind of these community access points for people. And so they have this goal of a patient will never need to travel more than, let's say, 30 miles or 20 miles for care. And so we're going to create these nodes in communities, and it could be partnering with public health departments or FQHCs or rural health clinics or any other facility where the patient has a room and they can do telehealth consults in that room, and maybe you have a contract with them to pay them a little bit of a facility fee to help you navigate their patients. And now you're seeing patients at someone else's facility. It might not even be a facility owned by you, but that is a clinician to a patient at a healthcare facility model of telehealth. The clinician can be at home. So again, thinking about that, the patient could be at a facility, the clinician could be at home, thinking about the work-life balance piece. But you can also have the clinician to a patient at a non-healthcare facility, thinking about all those access points. Where are patients when they need care? Home is obviously a no-brainer, but they could be at school. So school-based health clinics have become an emerging model. Workplace models have become an emerging model as well. Are there some places, like poultry factories and places where it's very hard for people to take leave to go visit? Can you set up a little virtual clinic there so that you can test for COVID and give them the results and help them understand what's going on? But then at the same time, really do some chronic care management as well. Clinician to clinician models. So we have the synchronous models. Most of you are probably familiar with Project Echo. If you're not, it is a model that was developed back been a while now in New Mexico to deal with the hepatitis issue. And it has grown to just about any specialty and subspecialty area where primary care providers are connecting regularly with an interprofessional team, reviewing cases and really learning, getting some didactic with the goal of keeping those patients in that primary care setting, helping primary care providers and other frontline providers be more comfortable hanging on to patients that they normally would just refer because they either haven't been trained in that or they're just not comfortable because they haven't kept up. It's impossible to keep up with all the changes in medications, with technologies, with treatment, with evidence-based. And so if you don't deal with some of these conditions all the time, you're just not comfortable treating that, even though you could. E-consults is the asynchronous version of that. So sending the patient record to a specialist for a review and via a portal or electronic medical record type of software platform, and then getting a response from that. So instead of physically sending the patient, you're really just communicating the patient data and getting a consult from a specialist. So provider to provider consults. We'll learn about all the possibilities because there are so many. And I think this reiterates my piece about, that telehealth is just a tool. So it's not in-person care versus telehealth, but in-person care plus telehealth. What does the telehealth component add? And we typically are calling it hybrid care now, as people are flipping to this hybrid care model. Learn about what program models work, particularly for your patient population. You know your patient demographics better than most of us, but there are all sorts of model kind of websites. There's an innovation exchange, there's rural telehealth toolkits, there's evidence-based best practices guides. There are a lot of things out there now that show like what works, what doesn't work, and for what patient populations. So really think about that. And then I also tell people, make a true commitment to excellence. So quality and safety are not things that we dispose of. I really hate it when people say telehealth is lesser quality care, because it should not be. We should be meeting the same standards of care, whether we're providing care in person or telehealth. The challenge is that we don't measure in-person care. And in-person care is very variable. If you go to one provider and you go to another provider for the same condition, you may get very, very different care. The quality of care is really dependent on the clinician's skills, the clinician's interpersonal skills as well as their judgment. And we have clinicians that are wonderful, and they're wonderful in person as well as by telehealth. But we also have providers that we would not send our family members to, whether it's in person or telehealth. And so just think about it in that same context. You're going to have some telehealth providers that are horrible, but mostly because they're horrible clinicians. And if they have terrible bedside manner in in-person care, they're going to have terrible bedside manner in virtual care as well. And so really think about that context. The standard of care is always going to be the standard of care, and we should not allow it to drop because we're using a telehealth way of delivering that care. But we do need to fix a lot of the sloppiness that has happened because of the pandemic. There are best practices, I mentioned that earlier. There are a lot of best practices that have been developed, but most of our providers have flipped to telehealth on a dime and never got any training on best practices. And so we need to now go back a few steps and really do some of this training. And those best practices relate to everything from best practices regarding workflow. I know, I talk about telehealth as a solution to provider burnout, but it's only if you implement best practices. When we did that rapid pivot, and I think most of you were probably in this boat, the provider ended up doing everything because we were not incorporating the whole care team in care, right? All of a sudden the provider is at home or in the office seeing patients at home, and suddenly the provider was the technician who was troubleshooting the technology with the patient, helping the patient install the technology. The provider then, instead of having somebody room the patient and prepare the patient and do the vitals and all that, the provider was suddenly, rooming the patient virtually, then trying to figure out how to get the vitals. And then when the visit was over, the provider was then going, okay, well, then normally have someone who schedules the next visit, but since I don't have that in telehealth, I'm going to figure out how to schedule my own next visits and then take my notes and document those. And the provider was truly like burning out because they were doing the functions of all the people that their staff were trying to do. And so best practices really is navigating the workflow and involving all your staff. And so that's one of the things that we really say, like, we need to do some training on this. How do we do workflow? How do you engage all your staff in the telehealth visit? So I'm going to talk a little bit about this workflow piece because I think it's really important. When we think about workflow, we think about everything from scheduling to who's doing your documentation and entry to who and this plays a huge role in the provider satisfaction realm, but then we also think about the patient satisfaction realm of things. So when a patient is in the office, oftentimes we do things like we communicate, that the provider is running late, or do you want to reschedule because their schedule is like really messed up today and they're 2 hours late. And you're in a telehealth visit, you might have a patient sitting in the waiting room. Who's communicating with that patient? Usually no one. They're just sitting there and they don't know what's going on. Why, my appointment was 10 minutes ago and I'm still sitting here in the waiting room. So we really need to think about the patient experience as well. And so when we think about the in-person experience, we think about, well, you put them in a waiting room and you give them at least reading materials, right? Like there's some magazines to read, or there's a newspaper, or we give them some health information. We put some monitors up with health information. So what happens in the telehealth experience? They might be in that waiting room with nothing. There's no music playing, there's nothing to read, there's no information being sent to the patient. So really think about that as well. And then there's this whole piece about etiquette. There's good etiquette and there's very poor etiquette. It's the same as the bedside manner. And your patient experience will often be grounded in the provider ability to provide good etiquette in a video conference call. So that's everything from your lighting to your sound quality, the position of the camera, and those things make a difference for the patient experience. So we also think about both effective and efficient care. So oftentimes we think about effective care, like does it work? But we oftentimes don't think about efficient care. So if it's taking you 3 times as long to do a telehealth visit, which it shouldn't, but if it is, it may be effective care, you're figuring out how to do it well, but it's certainly not efficient care. And so one of the things we also talk about in terms of training providers is how do you do a physical exam by telehealth? And it's a very different skill, especially if you don't have peripheral devices, because then you're really trying to teach a provider to teach a patient to be your hands. Um, and that means you're really learning a whole set of verbal skills. And oftentimes when I do trainings on this, I say, if you can take a 9 or 10-year-old child and teach them how to palpate an area and tell you if it hurts or if it's swollen, if you can take a 9 or 10-year-old child and help them, do like jump up and down to see if their abdomen hurts, if you can do that, then you can do it for anyone. And so you need to practice those skills. You need to work on your language because oftentimes we use kind of medical jargon that your typical 9 or 10-year-old would have no idea. And even the word palpate, you're like, what? You want me to do what? So if you can do that with a 9 and 10-year-old, then you can probably do it with the patient. And so that is a skill set that you need to learn. So consider what you would want for your own and your family's care. I think, we always think about like, what do I want for the care? And I think for me, I would want care at any time, anywhere that care is needed. Instead of come into the office, make an appointment, it could be 3 weeks from now. So how do we provide that? I want my care and my family's care to be team-based. If they need a specialist, if they need a social worker, I want all these people to actually be communicating with each other in some meaningful way. I want, so that I don't have to rely on so-and-so translating so-and-so's, instructions to another person and basically playing telephone, and you don't know what communication is getting lost. I want my care to be continuous. If I have a chronic disease I'm trying to manage, I don't want to come in every 3 months or 6 months or 9 months and and figure out whether I'm doing better. Like, I want to know if I'm doing better now, in these next couple months. I want to know, if that medication is working. I want my relationship to be personal. I want to be known, and I want my provider to really understand my context, my family, my stresses, my home environment. I want my provider to know that I can't do a telehealth visit because I may be in a potential domestic violence situation and I need a private space to do that. I want, them to know generations of my family and that, I have genetic kind of issues that have gone on in my family. And so I think we all want that, but we also want population-based health. We want to be able to influence the health of a population. So how do we do that? And we really want to be able to prevent things, right? We really want to catch things upstream before everyone falls into the stream and we're trying to fish them out of the river or or the ocean. And so, how do we get there? And where do we move from? And I think once we have thought those things through, then we think about technology. And this is always the kind of laughable teaching point. Most of the time when we say, hey, we want to do telehealth, what technology should we use? And that's almost always the first question that comes out of people's mouths. And I say, look, let's back up. Technology should be the last thing that you think about. The first thing you think about is what problem are you trying to solve? So let's go through this. What program model do you want to use to solve that problem? What are your patient demographics like? So what can they do and can't do well with technology? Then really thinking about workflow. What is the workflow I need to make my providers happy and to make my patients happy? Now, when I have all of those things in place, I go to the technology and I go, here are my requirements. What can you do for me? So it's no longer the vendor selling you the bill of goods that you may or may not need. It's you driving that discussion. This is what I need. This is exactly what I need. This is precisely what I need. What can you do? And when you shop technology, that's when you will find something that will make things work for you, as opposed to making the technology drive what you can and can't do. Now, most of us have probably flipped to technology selection prior to this, and that's fine. But still do the work, because at some point you're going to iterate to a new technology. or new technologies will be developed, or you might apply for a grant because you're not happy with what you have. So do the best with what you have, but then have that gold standard in mind of what you want, um, so that you can be looking for that right technology, the right fit, and applying for that grant, or or new funds come down. A lot of us have some opportunities with the COVID money at the state level as well as the federal money, to do something different. And so be thinking about what you want and what you need, so that when those opportunities come down, you know exactly what you're looking for. So now that we've talked a little bit about what you can and should be doing, I also want to give you a little vision for kind of the future and where things are moving to from a telehealth perspective. There are some real trends in telehealth technologies that I think are going to be game changers. And this is my perspective on this, but one of which is gamification in healthcare. I think we're seeing a real trend, and this is the patient engagement piece. So gamification builds motivation into behavior change, and most of us are not motivated by the lecture. Most of us are not motivated by sitting on the webinar and hearing like why we should be exercising. Um, but many more of us are more motivated by wearing that Fitbit that tells you you've met your goals for today, and the little stars flash, or and particularly like with nutrition things, being able to score points. And this is particularly useful for kids, but very useful for adults as well. And so we're starting to see a trend where apps and software developers are starting to build in some of these motivational principles related to game principles. So earning points, getting points, competing with your neighbor for the number of steps that you take, all things build motivation that is out beyond the sitting in a lecture and like intellectually knowing that this is good for me, but taking that next step is completely like beyond me. So one example of this is a blood glucose monitor that now plugs into the Nintendo DS or the DS Lite, and it rewards kids for consistent testing. That's just one example of many examples of things that are now happening in this space. Virtual reality is something that we are seeing. I heard rumor that uh, even WebEx is building into it a VR component so that you can um, add a VR module and then do a WebEx consult with someone and have them, use VR to do this. Well, what can you do with VR? Virtual reality basically simulates an environment, a person's environment, with whatever that environment might be, and it puts them in that space. And what we found is that this computer generated environment actually changes the way that they interact. So it can change their blood pressure, it can change their pulse rate. So imagine someone with PTSD, let's say a veteran, and this is used very effectively with veterans with PTSD, who's now immersed in a battle scene. And then you are talking them through, like, all right, breathe differently. Let's teach you to breathe this while all these battle sounds are happening, gunshots are going on. Think about the power of that. Someone who has fear of heights. But really neat example of this is using VR to lower pain and stress management. So the Children's Hospital in Oakland has been using virtual reality to help patients with sickle cell disease mitigate their pain. And so placing them in a less stressful environment in their virtual space while they're in the hospital experiencing intense pain has decreased their pain level and decreased the need for pain medications. Think about that in terms of like opioids. Can we help people manage some of their pains without medication? And can we then mitigate the use for some of the opioids that has created all these addictions? So again, we're seeing that being used. Smart pills, these are already in existence, but there are pills that can be swallowed and that actually go through your system, just like any other pill. Um, but they have electronic devices that are embedded, so they actually can diagnostically image things that are going on. They can monitor vital signs. We now have contact lenses that actually measure glucose readings. So if you have patients who wear contact lenses, Imagine keeping a continuous glucose reading without the patient having to do anything other than wear the contact lenses all day. So we're going to see sensors being developed at a fairly rapid pace, wearable devices as well as ingestible devices. We're seeing the use of artificial intelligence. Most of you have probably experienced a little bit of the AI chatbot light with COVID in the symptom monitoring. So, if you report this particular symptom, you get automatically moved to a different menu of responses and questions. If you report no symptoms, it lets you end the survey right there. But we're going to see much more of the use of AI and chatbots for screening, for emotional and emergency first aid types of situations, and for medication and care management. So helping patients who, let's say, need medication reminders or birth control pill adjustments or things, being able to do some of that through a chatbot and some AI-driven pieces. So I wanted to give you just a little bit of an example of what artificial intelligence coupled with robotics looks like. And I can't remember if I enabled video. So hold on, let me stop sharing for a real second and make sure that I enable the audio. Right. I'm going to play a little bit of a video for you. And I think this is kind of an exciting thing for this next generation of AI-driven potential healthcare.
Would you like to hear a song?
Yeah, absolutely.
I hope you enjoy my version of These Boots Are Made for Walking.
Stevie is what's called a socially assistive robot. And by this we mean it's much like any other robot. It has sensors and motors that enable it to move around in the environment, but it also has more human-like features that allow it to interact socially with people.
069, 069. I heard the summer was good this year.
Robotics has the potential to play a huge role in elder care facilities and hospitals to be able to enable people to do more with less.
Technology then becomes a force multiplier, if you will, to allow humans and caregivers to provide better care. If we can use robots and different technological solutions to automate mundane processes, it frees people up to be more human in the caring process.
So, technology will never replace humans, but I think it can replace some of the functions that we require humans to do so that humans can do the things that humans need to do, the touching, the talking, the conversations. And so we really need to think about that. But we've also been very, very astutely aware of the challenge before us. And this is the health equity issue. And we really need to understand that, we've been putting telehealth out there as kind of the solution for access to care, but we're also understanding that it's also has the potential for exacerbating the disparities in care. And we've definitely seen a lot of that during this pandemic. We know that broadband is an issue for everyone, every state, even in some urban centers where, cell phones and cell technology has not actually been deployed very well because they're a low-income community and they're not the lucrative area where these telecom companies want to enter. So we know that rural areas definitely have some challenges. We also understand that it's not just broadband. So there are areas that have broadband, but people don't have the digital technologies needed. So whether it's laptops or computers or tablets or even smartphones. And what we're also understanding is that people may, we see this data, like 85% of Americans have a smartphone. Well, that may be true, but they may not have the latest generation of smartphone. And oftentimes our software platforms and our device, many of the things that we are using for video conference require you to have the most up-to-date operating system. And so if you think about a family who might have, 2 or 3 kids, well, the iPhone, 8 gets passed down to the next person who's still using the iPhone 6, who's using the iPhone 4. And suddenly, 85% of people have smartphones, but not all of them can actually enable video and use the software that we need to do a telehealth visit with them. We also have digital literacy challenges. We think about that with the elderly, but we also often don't think about it with people who speak different languages, who come from different countries. We also have interesting challenges with privacy. So we are alienating a whole group of people, oftentimes with telehealth visits, who have have extreme privacy challenges. So these are people with sometimes mental health disorders who are living in households with many people, and they don't have a place where they can have a private visit. They can be LGBTQ populations or transgender populations who are having real challenges with having visits and feeling like they can trust and be private in those conversations. We have populations who are in domestic violence or abuse situations that don't have this private space to have telehealth visits. So I think we need to really think about that. We also have subpopulations like the Amish, the Mennonite, who have both religious and moral beliefs about technology and what can and can't be used. And we really need to think about that. So there are definitely pockets of the population where telehealth can definitely help them, but they may be sometimes excluded systematically from using telehealth applications for a variety of reasons. So I really challenge people to think outside the box. Not everyone is going to have a device. Not everyone is not going to know how to use a device. Not everyone is going to have a private space to actually have those telehealth encounters. So how do we think outside the box? Delaware Libraries has been putting in kiosks. I think we did a webinar on that, very interesting, but they have said that the kiosk has not been as popular as the loaning system. So you can then check out a device from the library, whether it's a tablet, a laptop, and you can do your telehealth visits that way. Now think about, the group that we usually don't think about are adolescents. But if you think about the privacy issue, who owns their phone? It's usually their parents. So if they're trying to have, let's say, a Planned Parenthood visit or a contraceptive visit, and the device is owned by a parent and can be turned on and off by the parent, or the apps on their phone can be viewed by the parent, that is a challenge, a privacy challenge. And suddenly we have a group that's very high tech that may have full access to broadband, but they are not able to access the telehealth visits they need. So we really need to think broadly about some of these populations as well, and how do you, then maybe they can go to the public library or the school library and check out a device for a visit that has some of these apps already loaded so that they don't have to download it onto their own phones because their parents or their caregivers are monitoring their devices. So really needing to think about that as well. We have had rural communities who have piggybacked on their community development and economic kind of development initiatives. So there are many Main Street initiatives trying to revitalize kind of the community's Main Street. So how do you take, let's say, an abandoned storefront and put in some kiosks or some partitions, so some soundproofing, and give people a space, enable the router to have Wi-Fi access so that people can come in with, their cell phone or whatever, or even enable some devices or tablets that they can check out and bring in to these storefronts and have a telehealth visit, or a visit with an attorney because they're in a domestic violence situation and they don't have a place to have those conversations securely. And I think there are many uses for this, not to mention some of the educational opportunities that people miss because they don't have that either privacy or internet access or device. Thinking outside the box also, we have seen this growth of ride sharing services being used for healthcare. So initially, prior to the pandemic, it was partnerships were developed to actually transport patients to visits, which did cut down on no-shows. But now we're starting to see conversations being made about transporting devices to homes. So if your patient doesn't have, let's say, a digital otoscope and you're trying to diagnose an ear infection, but they are immunocompromised, how do you deal with that? So maybe your practice has, a set of otoscopes that can go to the home, and you call the Uber or the Lyft or whatever ride sharing service to come pick up the device and take it over there. And then you have, let's say, you then take AmeriCorps volunteers who are then trained to help with technology navigation, and they help the patient to set up those devices in the home. And then now you can do a telehealth consult and you can see inside the ear, and that patient no longer has to come into the office. So really thinking outside the box, I think thinking creatively can get us a long ways to dealing with some of these health equity issues. I like to think about this culture of innovation and like, what would you do if you weren't afraid to innovate? How would you sit down with your team, your staff, and really think about innovation solutions that might be non-traditional partners using non-traditional devices to do some of these better care. And like, imagine a better future in your care. This whole term connected care basically leverages technology to deliver patient care outside a hospital or doctor's office. We have heard data that shows that as much as 70% to 80% of the in-person care can technically be done outside of the office setting. And so as you think about all the care that is currently delivered in the office, what are the outside of the box ways that you can think of that can maybe move that to the home setting instead of having people having to come in? And so I wanted to kind of end with just a couple of videos that give you a glimpse of what care could be in the future. There are a set of kind of case studies that were done by Kaiser Permanente through their innovation center. These are like 5 years old already, yet they still like have that wow factor. I'm just going to do one little clip of them. This one is from a Medicare scenario. They have a bunch of different stories. But think about what this would be like. And remember, this was over 5 years old, and all the technologies that were in this particular brief segment, and there are like 5 videos that tell this story. I'm just going to do the first one to give you a glimpse of it. All of these technologies actually already exist today. It's just that people have not put it all together.
Hello?
Hi, this is Joe. I'm a KP avatar. From the readings on Leo's bracelet, we've noticed that he's having some trouble breathing.
Well, we just had a heavy breakfast and we took a long walk to the hardware store. So he probably just had too much to eat.
It might be nothing at all, but we'd like to take a closer look at him. I've located a Medicar nearby.
I'm fine, Rosemary.
I know you are, but why don't we just let him take a quick look?
Great. It will be there in less than a minute.
Okay, thank you. Thank you. Feeling all right?
How are you feeling?
I'm fine.
I noticed that you have some difficulty breathing. Do you have any shortness of breath? Any pain?
I said I'm fine. I just ate too much.
Okay, well, let's do a few tests to make sure. Put your finger on the pad so that we can get a pulse oximetry reading. And I'd like to run a quick blood test. Please put your finger in the small compartment on your right. I'd like to bring in a physician and your navigator right now to review the results with you.
So just a quick glimpse of, and remember, all these technologies actually exist already today. This will give you another glimpse of holographic technology that is currently in use in Australia.
At Silverchain, our vision is to deliver the world's best health and aged care in people's homes so they can live their whole lives as they choose. We know that Australia's demand for healthcare is increasing, partly because of an ageing population, but also because of the increased number of things we can do in hospitals. And our research shows that about 30% of people in Australian public hospitals today don't need to be there. And we know we can deliver them really high quality care at home. Now this will not only increase the safety, increase the convenience and be what people prefer, but it will relieve the pressure on our public hospital system for people who really do need that level of care. Our new technologies allow nurses who are on a day-to-day basis responding to clients in their home to be able to have really good access to the data, be able to have their hands free while they're reading data, but also importantly consult with a doctor and have the doctor see what the nurse is seeing and the data at the same time as giving the nurse advice about how to treat the patients. This significantly increases the capacity of the nurse to practice at the top of her profession, and it gives the doctors an incredibly efficient way of being in many places at once. Enhanced medical mixed reality, or EMO as we call it, creates a hologram of a doctor. So the experience is a doctor's really personally in your home, talking to you, in dialogue with you, looking at you and consulting with you about your healthcare. So the experience is a doctor has come to your home and visited you. We think this is going to meet the demand for increasing healthcare for our community in a way that's not only less expensive, but is much closer to what people want and takes the pressure off our hospitals for the future. It's part of our vision for a new generation of healthcare for Australia, and it's coming soon.
So we're really not that far away from most of these things, but I think it does require outside of the box thinking to piece all this together. Again, I said like all these technologies actually exist. Uber is actually using some self-driving cars, and obviously you know about the self-driving cars that are out there right now. But even if we use, person driving cars, but had equipped them with some medical sensors and devices so that we can actually deploy a mobile unit to a patient at their point of need, think about what that would do to transform the way that we deliver care today. Maybe we don't need all those bricks and mortar facilities. Maybe we just need a handful of those, and we can have much of that being done mobile. So again, this health equity issue, how do we do this together? How do we really think outside the box and piece together what we already have, the infrastructure that we already have to deliver care better, more efficiently, and more effectively to the populations who most need it? I think we all have an opportunity right now to do that. And so I wanted to end with just a few resources for you. As I mentioned, I am the Mid-Atlantic Telehealth Resource Center, and we are a consortium of telehealth resource centers that are funded by HRSA. I serve the dark purple states, so Maryland is obviously one of those. We cover every state in the country, plus many of the US affiliated territories. And there is one wherever you move to. So as long as you're in the country or in a US affiliated territory, you will have a resource center. Our services are completely free of charge, or at least 99% of them are. And we do everything from answering simple questions to more deeper dive, what technology is out there? What can I do to meet some of the needs? What program models might be out there? So we are here to really help you soup to nuts with telehealth. One of the technology assistance or telehealth resource centers is the Telehealth Policy Resource Center, and they are a national entity. It's based out of the Center for Connected Health Policy. And if you ever have questions about telehealth policy, they have a searchable database that goes by state. You can look up Maryland policies. You can look at COVID-19 specific policies, whether they're still active or not. Medicaid, private payer, professional licensing board policies. They also have a database that is pending, so proposed legislation and regulations. So if you know things that are potentially coming down the pike or have been introduced, we have a technology resource, technology assessment resource center, and they're really focused on helping people navigate the technology space. They have toolkits on, let's say, video and otoscopes and stethoscopes. Really great information there. This is us. So we are the Mid-Atlantic, matrc.org. This is our website. We have a lot of resources on our website. But the way that we operate is we have a network of consultative service partners. When you reach out to us for a technical assistance request, you will usually either get myself or Anita as the first line. If we can answer your questions pretty quickly with a video visit or an email exchange, or directing you to some resources on the website, we will do that. If it's a much more in-depth question, like we need someone to really come to our facility and kind of help our staff with workflow development, or walk us through how to start a program, or do some intensive training on telehealth etiquette at a staff meeting. I will usually hand those off to one of our consultative service partners to work with you, and they are basically on retainer with me through the grant, and so they bill us, and they give you the services for free. We also have virtual office hours in 4 topic areas: school-based telehealth, telehealth basics and telemental health, working with technology and vendors, and then remote patient monitoring. Our remote patient monitoring one, strangely enough, has not been very widely utilized. So if that is an interest of yours, we are probably going to discontinue that come the new year. So if you're interested in that, make use of that in the next 2 months. But we basically have some of our professionals available for 1 hour, 2 hour blocks, once, twice a month, sometimes more than that. And you can just connect via Zoom link and ask questions, do some brainstorming. They're just available. And you can join at the top of the hour or anywhere in between, ask a quick question and leave, or spend the whole hour talking and brainstorming. So that is available to you all on a regular basis. We have hot topic toolkits on our website. And we also have a conference coming up, and we do an annual conference. It's April 24th through 26th. It's going to be hybrid this year. So we move it around. This year is going to be in North Carolina. So it should be in at least driving distance for most folks. But we will have the hybrid version as well. So everything that will be available on site will also be available online. And we do offer group discounts. So if you are doing the online model, you can buy one and include like up to 2 other people. We have a group rate. So that's really great for nonprofits who are in this space. We also have scholarships available. They're only available, I can't remember the date, but you can apply for scholarships up through, I think it's like January of this year. So if you want to attend in person or even virtually and you cannot afford to do so, please just go online and apply for one of our scholarships. They're made available through grant funds, as well as through many of our vendors will sponsor or donate. And we actually have individuals donating towards scholarships as well. So we try to make sure that as many people who want to attend can. We are having a telebehavioral health track specifically, and we started that last year and we'll continue this year. We also have a leading change track. So if you are one of those people in your organization trying to think about innovation and wanting to kind of move an organization to changing the way that we do business or thinking outside the box, we will have a leading change track this year. That'll be new. We have the COVID-19 toolkit, which is a great one for those who are really wanting to learn best practices, everything from telehealth etiquette videos to telehealth physical exam videos. We also have other training resources there. We have captured best practices and lessons learned through COVID for our region. This is still in beta version. There are a couple glitches to this still, but we should be fully functioning next week. But you can really look by, like best practices for solo practitioners. We have toolkits for working in correctional settings and toolkits, implementation toolkits, as well as success stories. And then the rest of the slides, I'm not going to go through them all. I think the slides will be made available to you. But what I've done is compiled a bunch of resources for telehealth equity. There are many organizations have cropped up as a result of the pandemic. This is one of them. It's called Telehealth Access for Seniors. It's a little bit of a misnomer, but they work with seniors and low-income communities, and particularly with nonprofits working with low-income communities. They have tech guides. They have translated guides in different languages. They have actually people on call to help people navigate technology. You can connect with them if you are a nonprofit working with low-income communities, and they also refurbish devices that then can be disseminated for free for people. But a lot more, there's a Telehealth Equity Coalition, National Digital Equity Center, DigiUnity, which looks at the broadband issue and computers. This organization actually gives devices to people who are isolated because of COVID so that they can connect with family and friends. This looks at adaptive devices for those with vision and hearing impairments. Most states have the AT3 centers as well for that purpose. Broadband, low-cost internet resources, emergency broadband benefit. Most of you are probably aware of that. And this is my contact information. So I wanted to leave a few minutes for Q&A.
Well, thank you, Dr. Wibberley, for joining us. If anyone has any questions, feel free to unmute and ask, or if you want to drop those in the chat, I'll just read them off to her. While we're waiting on that, in the meantime, I will make the PDF of the slides available. That'll be coming after the conclusion of this. You should see that come in your inbox. That'll just come from me directly. So if you have any questions, you can just email me right back. And then you'll also see the instructions for claiming credits for the webinar in that email as well. And if you have any issues with those, get in touch with me. I can always reach out to the accreditor if there's some issue on their end, and we can get that resolved fairly quickly. And the other thing that you'll see from me is a link to the survey that will follow this. That should be in by the, you should see that from me by close of business today. And if you would take just a little bit of time to respond to that, we would greatly appreciate it. So if anyone has any questions, drop them in the chat or feel free to unmute and ask away.
Lots of silence. So let me give you just a couple of tidbits for those of you who are, this is part of some of the best practices trainings that we do. But you know, for those of you who are really have been just doing telehealth to people's homes, I think there are a couple of best practices that I like to share with people. So one question that people always provide is, you know, what do you do if someone is in a situation where, let's say, there's domestic violence or their privacy is an issue? And we do this in our mental health trainings, but we also advocate this for other spaces as well. So we say one of the best practices is to develop a either password or passphrase with that patient or client. So if you usually do this by phone so that they can do this in privacy and say, you know, what is the passphrase or passcode that we want to use? And you would start every visit with that. It could be a very simple thing like, you know, we're going to use have you gone to Walmart today? And, you know, answer yes or no. Is it safe to talk or have this conversation? And you can always have the patient or client come up with something so that if somebody walks in the room where they feel not safe, they will say it. So it could be and have the patient come up with it so they'll remember. It could be something simple like, you know, what's your favorite fruit? Pineapple. All right, well, when you say pineapple, it means we discontinue this conversation that we're having and we talk about something generic. So I think that's one thing that we like to say. Another thing is for those who are, you know, having challenges with, let's say, potential mental health crisis or physical health crisis. In a telehealth visit, you know, obviously if you call 911, if the patient's having an issue, 911 is showing up at your door. We do not have a national 911 system. And so 911, if you call and you get your local 911, they will basically have to Google the 911 where your patient's address is. And so you might as well save them the step and do it yourself. And so we say document in your notes the patient's physical address whenever you're doing a visit. Google the emergency and non-emergency number in case you need to do either a welfare check or an actual like emergency number and put that in the case note. And then at the start of the visit, just verify that they are at the location where you have documented. And if they're not, put the new address down. And that way you can definitely, you know, hit on that. But we also say most of you have intake forms or other patient registration forms. We advocate putting down not just an emergency contact, because people put emergency contacts and they could be like, you know, my mother-in-law, like who lives halfway across the country as my emergency contact. We say like, hey, can you put down a kind of a telehealth safety check contact? And that would be someone who can reach you and can be at your home in 15 or 20 minutes. Because you basically say, hey, you know, I am away from, I'm like a good, you know, I don't live anywhere near you. I can't be there if something happens, if you, you know, fall down and break a leg. Is there someone that you could put down that you give us permission to contact if we feel like there might be an emergency or something is going on that can be at your home, you know, in 10 to 15 minutes? It could be a neighbor, it could be, you know, a friend, it could be a colleague, whoever that be. And most people are willing to put something like that down. So that's always a good thing to have in your notes. And it also helps for those, if you need to do a welfare check, but you don't want to call the police because you don't want to traumatize someone. People have had traumatic responses or experiences with police. And so that way you have someone that you can call for a welfare check that's not law enforcement. So just a handful of kind of things that we have found helpful for people.
Fantastic. Well, there's a lot of thank yous and a lot of great presentations in the chat. I will wholeheartedly second that. Thank you so much for spending time with us today and for sharing all of this information. I learned something new every time I attend something on telehealth. It is absolutely fascinating the way that it is being implemented and used. So just thank you again, Dr. Werberly.
Thank you. And definitely reach out if you have questions or you know, just want to brainstorm.
Great. Yes. Her information will be it was on the last slide. You'll all see that as well. You can contact me as well if you need to. And if there are no questions or anything like that, then I will wish you all the best of the rest of the week and have a great day.